Hello everyone, I am Dr. Adam Muhammad. We will discuss today Bankart lesion, one of the most sports injury in athletic adult, or it's named anterior inferior glenoid labral complex injuries. The cause of Bankart lesions is mainly due to anterior shoulder dislocation. Anterior shoulder dislocation. And the shoulder dislocation is due to fail in one of two systems or the two systems. First one, dynamic stabilizers. Here is weakness in this injury, anterior dislocation in rotator cuff or periscapular muscles, which may lead in the future to anterior dislocation. And the passive stabilizer like ligament, glenohumeral ligament, and capsule, maybe cracks or torn in the capsule or ligament, especially in Bankart lesion, inferior glenohumeral ligament, especially also anterior part. So Bankart lesion is torn in the glenoid labrum. Quick recap of the anatomy of the glenohumeral joint. Glenohumeral joint is composed of the humeral head and the glenoid cavity. Glenoid cavity is very shallow. Very shallow. So here is the glenoid labrum to deepen the shallowness of the glenoid. Because if there is no labrum, the humeral head easily dislocate from the glenoid cavity. So Bankart lesion, one of the most injuries related to anterior dislocation, and it will lead to chronic anterior shoulder instability. The Bankart lesion, two type, soft one, which discuss it now, torn in the labrum, then capsule and the detachment of it from the glenoid. The second type, bony Bankart lesion, detachment of the bone itself in the same place, anterior inferior labral anterior inferior glenoid labrum, glenoid cavity, sorry. So when there is detachment of the labrum itself and part of capsule, we will call it soft type of Bankart lesion. When add another bony detachment, we will call it bony Bankart lesion. Okay, capsule and labrum related to each other. Capsule and labrum related to each other. This picture shows the glenoid labrum and joint capsule. In a Bankart lesion, the anterior inferior labrum is torn due to, as we discussed before, anterior shoulder dislocation. Since the labrum and capsule form one unit as shown in this picture, here is the labrum and the capsule form one unit. We call it laprocapsular complex. We call it laprocapsular complex. The tear often involves both structures, labrum and capsule, not just labrum. That's why in surgery, arthroscopic Bankart repair, both the labrum and capsule are reattached to the glenoid rim here. If not repaired, capsule with labrum, recurrent instability is very likely. How to assess anterior shoulder instability? By Oxford shoulder instability score. We ask the patient some questions like, do you feel that your shoulder slips out of place? Does your shoulder feel unstable? Do you feel the need to be careful with certain movement to avoid your shoulder slipping out? Does your shoulder cause you pain? Does your shoulder problem disturb your sleep? Does your shoulder affect your ability to dress yourself, especially putting clothes on over your head, sorry? Does your shoulder affect your ability to comb or wash your hair? Does your shoulder affect your ability to wash your back? Does your shoulder affect your ability to carry shopping bags? Does your shoulder affect your ability to play sport or do hobbies? Does your shoulder affect your everyday life in general? How would you describe your shoulder overall? This is Oxford Shoulder Instability Score. Scoring system, each question scored 1 to 5. 1 worst case, 5 is the best. Total score range from 12 to 60. High score, better shoulder stability and function. Okay. After that, we will discuss the rehabilitation protocol post-arthroscopic surgery of Bankart lesion, which called Bankart repair. In the first 10 weeks, it is red flag. Red flag. Avoid it. Red flag. No resisted, active, isolated biceps activity. Elbow flexion or forearm supination in the first 10 weeks. No active external shoulder rotation, extension, or abduction. I said active in the first 2 weeks, and we will discuss it in the next slide. Okay. I wanted to ask, why no resisted biceps activity in the first 10 weeks? Because the long head of biceps attaches to the superior labrum, and any contraction put traction on the labrum biceps complex. That will may lead to risking failure of the repair. No active external rotation, as we said, or extension or abduction in first weeks, because this movement places the greatest tension on the anterior inferior capsule and labrum, the exact site of the Bankart repair. So doing them too early can compromise healing and cause recurrent instability. Okay. When we can do active external shoulder rotation, either internal rotation or external rotation. I wrote it in one slide. Sorry, I will get it. Okay, last slide. Shoulder rotation rehab, post Bankart repair. External rotation in first 4 weeks, just passive external rotation. as we discussed, it will put stress on the site of the lesion, on the repaired site. Okay, so first 4 weeks just passive and immobilization in sling. From 4 to 6 weeks passive external rotation until 20 degree. From 6 to 8 weeks active assisted external rotation. From 8 to 10 weeks submaximal seraband resisted exercise. From 10 to 12 weeks gradual toward maximal external rotation. Okay, internal rotation from 0 to 5 gentle passive internal rotation. From 4 to 6 weeks passive active assisted internal rotation. From 6 to 8 weeks submaximal controlled internal rotation. For in the week number 10 progress to maximal internal rotation. Finally, resistance for external and internal usually start from 6 to 8 weeks, maximal after 10 to 12 weeks, but monitor pain and instability. Okay, monitor pain and instability. Here we go back to discuss the another protocol of the rehab. As we said, shoulder sling for first 6 weeks. We tell the patient that he will sleep in sling in the first 3 weeks. Flexion and description to 90 degree. Active flexion and description to 90 degree. Flexion and scaption position in this picture. This scaption position. Here is flexion up to 90, not 118, 17 I think, just to 90 degree. Passive and gentle active assisted range of motion exercises to elbow joint and shoulder also and wrist, but wrist and elbow free range of motion. But remember, avoid elbow flexion, which did by biceps resisted exercise in the first 10 weeks. Okay, scapulothoracic range of motion, active range of motion in all planes. Hand gripping exercise. Here is a picture of hand gripping exercise. Mixed scissoring, finger scissor, fingertip bench, power grip, flat bench, finger spread, finger extension, finger spread, also full grip. Okay, in week 6 we initiate proprioceptive training, rhythmic stabilization drills, and gentle submaximal shoulder isometrics in week 6. Okay, here is a picture of rhythmic stabilization drills for flexion and extension with the arm elevated up to 90 degree. We make manual resistance to the upper limb for previous mentioned directions: flexion, extension, internal rotation, external rotation, abduction, adduction. Okay, also manual resistance from side lying, external rotation, and internal rotation here as discussed and showed in this picture. But no movement, isometric, just resistance. Just
Ow.
resistance.
Sorry.
In week 7 to 12, we will improve the program from slow to fast, slow, controlled arm raises by medicine ball, through by medicine ball, and random pattern as forward reaching, catching a ball from different direction, from random pattern, from known pattern to random pattern, from known pattern. As I tell the patient, I will push the ball toward him in the right side. This is the known pattern. Random pattern, I push in any side and the patient will catch the ball. Okay, eyes open and eyes closed, like push-up exercise on the wall, with eyes open and with eyes closed. From open kinetic chain exercise, it is easy after surgery, to when we need to progress to closed kinetic chain. Closed kinetic chain. Open chain exercise like dumbbell external rotation. Close the chain wall push up, I will show in picture. Like that, but exercise, but isometric resistance, not just pushing, to rhythmic stabilization drills which train the proprioception, like that. Like that. Here is a picture of closed kinetic chain, to the external rotation. Okay, and in week 12, okay, in week 12, we apply push-up exercise on pole or unstable surface, with rhythmic stabilization applied to the arm and trunk, manual resistance to the arm and manual resistance pushing to the trunk. Okay, we discussed this image, rhythmic stabilization drills in 90 degree of abduction and external rotation, the position of injury, but it is in week 12. And as we do it in close the kinetic chain, it is safe position. Okay, the final shape of this exercise, rhythmic stabilization drills during exercise table at 90 degree of abduction and 90 degree of external rotation, like that. He pull the strap like that, tapping, guys. Okay, no biceps loading until week 10. No biceps loading until week 10, as we said before. From week 7 to 12, submaximal isometric isolated biceps activity, elbow flexion and forearm supination. In week 10, we started horizontal abduction and extension initiating stretching exercise if range of motion not full by week 10. Continue isotonic progressive resistive exercise and manually resisted exercise. Week 13 to 26. External rotation at 90 degree. Abduction up to 120 degree. So throwers position. Isotonic elbow flexion and forearm supination. Spencer technique, we'll discuss it in next slide. And continue to progress resistive exercises. Continue to progress plyometric exercises. Here is the Spencer technique. It is composed technique of stretch and traction and compression and full range of motion for the glenohumeral joint. First stage, you start with extension, full extension. So we stretch the flexors and anterior capsule. Flexion, we stretch the extensors of the glenohumeral joint, like posterior deltoid and latissimus dorsi. Here is compression and circumduction for proprioception. Proprioception from this position, 90 and 90, 90 elbow, 90 shoulder. Okay. Compression and traction with upper limb straight and abduction to 90 degree and the full degree also from 90 to 100 and 18, 80 and 70. Okay. Internal rotation, full internal rotation, full glenohumeral joint bump, like bumping mechanism, pump something. Okay. Lastly, shoulder plyometric exercises and begin throwing full throwing from mount by the 25, 24 and 28 week. Okay. Plyometric exercise for the right arm, so that stand sideways, so that your left side is facing wall. Keep the right elbow tucked against your right side with the elbow at a right angle through a 2 pound ball. Cross the body, keeping the elbow tucked to the side. Okay. Catch the rebounded ball in the same arm position, allowing the arm to comfortably stretch back, and then quickly through the ball again. Okay. Don't pause or stop the ball movement after catching it, like that, as discussed in these pictures. Okay. Second exercise, wall dribbles overhead. Stand facing a wall with your arm held comfortably overhead, above the shoulder joint. Quickly dribble, like that. Quickly dribble 1 to 2 pound ball against the wall using your fingertips. Last exercise, rebounder throwing. Stand facing a rebounder with the arm raised in the throwing position. Throw 1 to 2 pound ball as we discussed before, and then catch the rebounded ball in the same throwing position. On the catch, allow the arm to return, allowing the arm to return and rotate backward, and the quickly throw the ball again. Don't pause or stop the ball movement after catching it. Thank you.